emergently, we're going to stick it right in there, go right into the right ventricle, and pace the patient. And here's a cardiac bypass machine. Here's an intra-aortic balloon pump, so you can see that if you put this in your aorta, when your heart contracts, it deflates to let all the blood go through, and when your heart relaxes, it's going to inflate and push back pressure into that heart. And so, you basically are improving that cardiac function. And even ECMO, if Bill Banner's in the room, he's sort of the ECMO expert, I think, that we have here. And he loves to mention that. But it's done for children. And if their heart and lungs aren't working, you can put them on this machine. You can cannulate their jugular and their carotid artery, and you put them on this machine, and it basically keeps them alive until the drug would be gone. But it certainly has been done in adults as well. And you can see that this is a huge undertaking, a huge device, usually much larger than the patient. Intralipids, I almost feel like I don't really need to say much about this, since we've actually had the pioneers of this here, and we've been able to hear them speak. But in case you missed it, maybe a lipid sink, maybe just a fatty substrate for the heart to work more efficiently. And the good thing is we see all these great case reports of people surviving cardiac arrest or severely ill clinically. And the bad, I think we're not really sure at this point. Could this cause pulmonary fat emboli? Could this cause pancreatitis? There certainly are issues with having too many lipids, but in an acute scenario, that may not be the issue. And really, these cases are ones that he talked about. This is with the anesthetic toxicity. This was an animal model that he's already spoken about. And this one is interesting. They tried, they used clomipramine to poison rats, and they gave them sodium versus lipid, and they actually found that the lipid reversed the toxicity better than the sodium bicarb. So with our lipids, we have them over here, filling up our vascular space. We may have a calcium channel blocker here, and we drop in our lipids and hopefully just suck that verapamil right out of there. Open up that calcium channel and increase contractility. Vasopressin and terlipressin. So anybody use this? Seen this before? No, not so much. But this is more of a European drug. We have vasopressin receptors certainly in our bodies. There are 3 different types, but the one we're most interested are in the V1, and these cause vasoconstriction. And so if you have, say, your resistance is poor, you can vasoconstrict them and increase their heart rate or their blood pressure. So the bad things is that may vasoconstrict other organs too. So it may even cause vasoconstriction of coronary arteries, and we know what that's going to do. So there's certainly many different case reports, case series in the literature. This study, interestingly, they poisoned pigs with bupivacaine and found that the epi and vasopressin had better results than the intralipid. So that was one sort of going against the intralipid. Certainly our reviews about it in this dog model with verapamil, they actually did not do well with the vasopressin. And this is a case report with a TCA, actually, that responded to vasopressin. So maybe there was enough alpha-1 blockade and they were hypotensive, they gave them vasopressin, contracted that, improved the blood pressure. So if we give them our vasopressin over here, we're going to cause some vasoconstriction. All right. Phosphodiesterase inhibitors. Anybody use milrinone? We're kind of getting old school here, right? Amrinone, milrinone, those kind of drugs. So those are phosphodiesterase inhibitors. So they inhibit this phosphodiesterase 3, and I'll show you on the diagram where that is in the cardiac myocyte. And the good things is that it may increase contractility. The bad is that it may vasodilate. And it has sort of a long half-life, so if you run into trouble, it's hard to get rid of it. And this study here with dogs poisoned with propranolol and then treated with amrinone versus glucagon, they found that they both would increase your cardiac contractility, and that in these dogs poisoned with verapamil, they found that the amrinone was better than placebo. And here was a case report here that it was actually glucagon and amrinone together treated a patient successfully. So right here is phosphodiesterase, and if you inhibit that, your cyclic AMP is not going to get metabolized. So you want to keep that cyclic AMP going, keeping the phosphorylation channels, opening the calcium, coming to your myofiber there and causing contraction and potentially vasodilation. And dopamine. Who's used dopamine? This is a common one, right? So we sort of, I don't know why, I guess we always think of dopamine, it's in our heads. And we know that it responds at different doses, right? So if it's less than 5 micrograms per kilo per minute, it's more of a renal dilator or splanchnic, increased splanchnic flow. And if it's up to 5 to 10, more of a beta-1 agonist. If it's greater than 10, more alpha-1. So that may work. We know norepinephrine will work on these, and so that looks like a pretty good choice. The bad side may be that it requires that you have catecholamines, because you need to secrete these. The dopamine causes the secretion of norepinephrine to get this effect, this high-level effect, and cause the vasoconstriction. So as in this retrospective human case series, TCAs decreasing sort of that storage of catecholamines did not do well with dopamine, and when they were put on norepinephrine, they got better. And this rat study actually found increased mortality with dopamine. One study I think is definitely worth reading, New England Journal just published this, 2010, it was I think a few weeks ago, and this was actually a randomized blinded study done in Europe, I'm not sure which country, but they compared dopamine and norepinephrine in just patients with shock, anybody with shock. And so they actually were blinded to the therapy, and they reviewed it, and they actually in the end found that it didn't really matter. Either way, the survival at 28 days was about the same. What was interesting is that the cardiogenic shock had less survival with dopamine. And so that may be pertinent to our patients, right, that have calcium channel blocker or beta blocker ingestions. So if everything works right with dopamine, we're going to increase contractility and vasoconstrict. All right, so we made it through. Anybody have any questions on any of those things right now? We're doing good for time here.
I have a question.
Yeah.
You were talking about glucagon. Do you notice that there's now, for beta blockers, that there's a trend that they're phasing out using glucagon and now going more to the high-dose insulin glucose?
I don't really see that necessarily.
I guess we do at our
You do?
center. There's a shift.
Mhm.
We used to always use it. Now we're shifting more towards the other.
I don't think that's necessarily a bad idea, but I think most people at the hospital that you're talking to aren't familiar with the insulin glucose. And so they're going to give them glucagon for a beta blocker.
And Can I actually, one more question? The sodium bicarb, like for a TCA that you're giving the sodium bicarb, you recommend bolus, but we recommend bolus as well, but when you call back, they're giving an infusion.
Yeah.
I don't know, why is there that hesitancy, or?
To bolus them?
Yeah.
You know, I'm not sure. Again, it's maybe just cultural. We often, you know, think of just, you put them on the drip and you're kind of done with them.
Right.
But I think, again, I sort of look at it as hyperkalemia with EKG changes. You have to do something right now because that patient's going to die. And so you have, just like with hyperkalemia, you have to bolus them with calcium, and you give them bicarb, you give them insulin, you give them Caxlate or dialyze, all those things. So for me, that rapid treatment makes sense. It's going to alkalize them. It's going to give them enough sodium, hopefully,
It's just
to change
sometimes we have reluctant,
Yeah.
you know, the
Because,
reluctance.
I mean, I think if you think of it too, is that so say it's a bicarb drip, it's like the one that you make for aspirin. You put 3 amps and you run it at 250 an hour, right? It's going to take 4 hours for maybe 150 milliequivalents to get in that patient. So if they're dying, they're probably going to, you know, continue on that pathway if it takes 4 hours to treat them rather than just giving them right away. But this was a case I had after I submitted this lecture. I thought, well, I thought I better save this patient since I'm doing this lecture. But this is a real patient, 21-year-old. I saw as a tox consultant. Took her mother's amlodipine. She was actually in a planned marriage and really didn't want to marry the guy, and decided she was going to end that with amlodipine. And so she actually showed up with a blood pressure of 92/30 and tachycardic and a little confused. And so I guess what would people start out with? Maybe a little fluids, right? Maybe some calcium, maybe some glucagon, see what happens. So she actually, you could see we were really worried that she got bradycardic because it actually seemed like this tachycardia was keeping her alive with this low blood pressure. And then all of a sudden she had this junctional rhythm at 65 and